I'm a very angry woman that this medicine has destroyed my health.
Each year, toxic side effects from prescription medicines injure tens of thousands of Americans. And sometimes it becomes big news.
Tonight, one of the most popular drugs taken for allergies is being pulled off the shelves in the U.S.
Since 1997, over a dozen drugs had to be taken off the market because of severe side effects.
Off the market.
Pulled from the market.
FDA administrators say these problems could not have been prevented.
At the time a drug is approved, we don't have all the information that we would like to have.
Off the market. Off the market.
But is there pressure on the FDA staff to allow dangerous drugs on the market?
I was told very explicitly, don't write in your review that you're recommending against approval.
Tonight, Frontline investigates the integrity of our drug safety system. Outside Washington, D.C. sit the main offices of the U.S. Food and Drug Administration, the guardian of drug safety in America. Here, every day, some 100 reports arrive, indicating that somebody somewhere has experienced a serious side effect with a drug. Back in 2000, an unusual number of reports started coming in about people like Angus Mclean, a retired naval intelligence expert. While raking leaves one weekend, Angus suddenly felt intense muscle pain all over his body, a severe reaction to a new statin drug he was taking to lower his cholesterol.
I was just sore, like you'd worked out too much. As this progressed over just a couple of days, it didn't respond to limbering up or my wife trying to give me a little rub down. In fact, it accelerated.
When his symptoms became severe, his wife rushed him to the hospital, where he was diagnosed with a life-threatening muscle-wasting condition called rhabdomyolysis. It's a rare side effect that can cause a person to lose vast numbers of muscle cells, which then have to be eliminated from the body. Angus required emergency kidney dialysis. For an entire week, he hovered on the edge of death, drifting in and out of consciousness.
When you're afraid to go to sleep, because you think, man, if I go to sleep and don't fight hard, then it's going to be over. You don't know how many times that creeps into your mind, but once is enough.
The drug that caused Angus's problem, Baycol, had recently been approved by the FDA.
I think Americans need to recognize that every time they put a pill in their mouth, especially a new pill that they've never taken before, it's an experiment.
Dr. Raymond Woosley runs a national center to study the side effects of drugs at the University of Arizona College of Medicine.
Morning.
He worries that most people don't understand how much about new drugs is unknown.
When a drug goes on the market, only about 3,000 patients have ever been given that drug. We will never know all the toxicity that can occur, especially the 1 in 10,000 or the 1 in 20,000 that could be seriously harmed. Our detection of that will only happen after the drug is on the market and exposed to huge numbers of patients.
Precisely because of such uncertainties, there's a special division at the FDA to monitor drugs after they go on the market.
I'm calling from the FDA, Office of Drug Safety. I'm calling in regard to a report that you had sent in to us earlier this year. The patient went into renal failure and wanted to...
The safety office at the FDA is staffed by about 50 pharmacists, doctors, and epidemiologists, plus support staff. They find out about what's going on in the outside world through MedWatch reports. Director of the division, Paul Seligman.
We receive approximately 1,000 reports every day at the FDA.
MedWatch reports typically start out when a doctor or nurse notices a problem after a patient gets a drug. But there's no legal obligation to report such problems.
In the United States, the initiator of the report does so on a voluntary basis. But it's critical that we get these reports. There's no other way that the FDA has for understanding what's going on with a medicine once it's been marketed without the voluntary reporting by astute clinicians and healthcare providers.
Doctors rarely contact the FDA directly. They usually send the reports to drug companies, which then are obligated to tell the agency about any adverse events.
If an adverse event is serious, which means it caused death, it resulted in hospitalization, or was potentially life-threatening or prolonged the hospitalization, the manufacturer has a legal responsibility to report that case to the FDA within 15 days of receipt.
MedWatch reports often don't contain enough details to determine if the suspected drug really caused the problem. So then the staff here has to contact the doctors who made the report. With nearly 300,000 MedWatch reports coming in every year, and over 3,000 drugs on the market to monitor, some critics say the job is just too overwhelming for the small staff here.
The number of people hired at the agency to protect, to analyze data on drug safety is criminal.
Dr. Woosley was a top candidate to head up the FDA last year, and believes safety should be a much higher priority at the agency.
The teams that are needed to do drug safety are infinitely more than what they've got right now. We don't have a safety system in this country.
It's indicated for the treatment of hypertension, may be used alone.
Dozens of new drugs come onto the market each year, continually adding to the FDA's burden.
How is cholesterol metabolized?
Some are completely new, while others are variations on existing products, like the many statin drugs, which are hugely popular for lowering cholesterol. America spends some $12 billion a year on statins, so there's a strong incentive to enter this competition with new products. And health insurers are always looking for cheaper alternatives. Which brings us back to the story of Angus Mclean. For more than a year, he had taken the industry leader Lipitor, which effectively controlled his cholesterol and didn't cause him any problems. But then the U.S. Navy switched him over to a new statin drug, Baycol, which was dramatically cheaper. Around the time Angus made the switch, Baycol was just capturing a significant share of the U.S. market. It had been a tough battle, because the originally approved dose didn't lower cholesterol as much or as fast as many other statins.
The FDA originally approved it at 0.2 milligrams, and 0.3 became an accepted use. But the problem was, to really compete in the marketplace, they had to be a much higher dosage than that.
Kip Petroff represents Angus Mclean and many others who have sued Bayer, the manufacturer of Baycol. He and other lawyers have uncovered detailed information about how the Baycol problem got out of hand. 2 years after approving Baycol, the FDA okayed a higher dose, 0.4. Sales started to rise, but soon Bayer began getting a troubling number of reports that patients were developing that muscle wasting condition, rhabdomyolysis. Since many had also taken a second cholesterol drug, gemfibrozil, in December 1999, Bayer sent out a letter warning physicians not to use the two drugs in combination. But almost half had taken Baycol alone, so Bayer continued its investigation.
When Bayer realized that they were getting increased numbers of reports, what they wanted to do was try to compare it to the other statins to see if the other statins had just as high an incidence.
To do that, the company asked the FDA for copies of all MedWatch reports associated with Baycol and its competitors. While Bayer was waiting for the information, a company memo shows there was growing concern among some doctors that Bayer wasn't being honest about what was going on. Board member thinks Bayer is not forthcoming. Dr. Palmer thinks Bayer is hiding something. Boston area cardiologists seem to be concerned about Baycol. After some rhabdomyolysis patients died, another company memo shows that Bayer was worried about the news getting out. The company's safety officer addressed this memo in a deposition.
Was there some effort being made at Bayer to try to keep information regarding these deaths related to Baycol quiet?
No.
Doesn't this, that ends with so much for keeping this quiet, doesn't that imply to you that somebody at least wanted to keep this quiet?
Objection form. I don't know
know what the context was. I can't get into the mind of the writer.
Well, the context is right here. There's widespread concern. People are hearing of things, and so much for keeping us quiet.
In the spring of 2000, Bayer received and analyzed the MedWatch reports it had requested from the FDA. Company officials compared Baycol with the industry leader Lipitor and got discouraging results. For every 100,000 prescriptions given without other cholesterol drugs, Baycol had 20 times more reports of rhabdomyolysis than Lipitor, also known by its chemical name atorvastatin. The situation was discussed at a July 2000 teleconference, where extensive notes were taken by Bayer safety officer Raj Sharma.
My note says clearly substantial increase than atorvastatin reporting rate, very strong signal.
Very strong signal.
That's correct.
And you underline that.
Yes.
A signal is meant to alert you to act, and there were people at that time in the middle of 2000 who, according to their own memos, we would do something now, is what some of these people were saying. If I had been at that meeting in July of 2000 and asked you, Dr. Sharma, can you tell me if you think this drug is safe? You would have said, I don't know.
Objection.
In July of 2000, wouldn't you?
At that time, we did not have the complete data to say whether it is safe or not safe.
What the drug company chose to do was study it further and continue marketing the drug as aggressively as possible. And that's where they crossed the line in terms of drug safety.
At the head office of the FDA's drug division, Frontline asked Deputy Director Stephen Galson if anybody at the FDA knew about the Lipitor-Baycol comparison.
We weren't aware at that point of the difference between Baycol and the other similar classes of drug. Our expectation is when a company becomes aware of a specific problem with their drug, they come to us.
With the FDA in the dark about Bayer's MedWatch report analysis, in the summer of 2000, the agency approved sales of Baycol 0.8, an even higher dose that Bayer needed to compete effectively against Lipitor. David Archer was one of many patients put on the new Baycol 0.8 dosage. He also was switched over from Lipitor, and his wife Lucy remembers that her husband was in excellent health until he began taking Baycol.
David was always very active. He would chop trees, he would do a lot of things. But then as he was taking the Baycol, I noticed as we walked especially, he would complain about his toes, then he would complain about the calf, his legs, and then his muscles and the back. Finally, it got so that he just couldn't seem to bend over to put his socks on and shoes. And no way had I ever thought that this Baycol was doing this. He took it October, November, and December. He was gone. He should have never died.
Lucy Archer's husband died more than 5 months after Bayer had strong indications their drug might be less safe than Lipitor. Bayer declined Frontline's request for an interview to explain why the company continued selling Baycol despite the safety concerns.
And in no case is a reporting rate from spontaneous data.
But company safety officials have had to answer questions in legal proceedings, where they have attacked the findings of their own MedWatch analysis. The problem, they said, is that this data depends on voluntary cooperation. Side effects for some drugs can get reported more often than for others, and only 1 to 10% of all side effects ever get reported.
The system is imperfect, and without being able to require people to make those reports, and we don't have the authority to do that, it's hard to increase it beyond that.
Well, the question here is, what is meaningful?
While sales of Baycol continued, Bayer conducted a new study that didn't use MedWatch data. After almost a year had gone by, the FDA began noticing increased problems with the higher Baycol dose and asked the company for its information.
They came to us with this study, which tended to minimize the problems with the drug. We didn't agree with them on this analysis, and this is why the action occurred.
The cholesterol-lowering drug Baycol is being pulled off the market.
It's been linked to 31 deaths in the U.S. from muscle destruction.
Under pressure from the FDA, Bayer voluntarily took Baycol off the market in August 2001, 2 years after first getting reports there might be problems with the drug. Although the company hasn't acknowledged any wrongdoing, Bayer paid an undisclosed amount to settle a lawsuit brought by the widow of David Archer. Bayer also settled a lawsuit with Angus Mclean, who now spends many hours each week trying to rebuild his muscle strength.
I didn't choose this, nor did I do anything that is overtly the cause of this. So I'm angry about it happening, but now that it's happened, what can I do about rectifying it?
Although Bayer has won a few jury trials in cases where it was unclear that Baycol caused the damage, the company has settled more than 1,200 lawsuits and paid over $430 million to victims. Beyond the harm done to individuals, though, the Baycol story reveals how dependent the FDA is on information supplied by drug companies.
The FDA is wholly dependent on trust, on trusting that the company is providing all the truth all the time, that the company is not hiding information, that the company is not covering up information, that the company is not changing information.
Dr. Leo Lutwak, a retired FDA drug reviewer, says reliance on companies was central to the biggest disaster in the agency's history, the Fen-Phen tragedy, in which 2 FDA-approved weight loss drugs injured tens of thousands of Americans. Lutwak struggled within the agency to keep those drugs out of consumers' hands.
I felt it was an open-shut case. This was a dangerous group of drugs with very little, if any, benefit, and that they should be immediately removed from the market, removed from use, discontinued, disappear. Well, that didn't happen. I became disturbed. I became concerned about the system. I became concerned about the drug company's role in this, and I was particularly concerned with the potential effect on the thousands of millions of people who would be using the drug.
Take a big deep breath for me.
Mamie Johnson from Houston, Texas, was just the sort of person Lutwak worried about when he considered the dangers of those diet drugs.
Deep breath.
I was really ready to lose some weight. That was the main reason I got on the Fen-Phen, because I thought it was a safe drug.
Mamie started taking Fen-Phen in 1995. A year later, she developed pulmonary hypertension, a constriction of blood vessels inside the lungs that dramatically reduces their ability to absorb oxygen.
It's a terrible feeling. You feel like you're passing out because you're not getting any oxygen. Oh, wait a minute, I have to rest a little bit. And then you start aching in your chest and your arms, and your fingers and things become numb. Oh, Lord. And right now it's still, after me getting my wind back, it's still a pain up in here. Curtis, you need to turn that oxygen up all the way.
The only cure is a lung transplant, but Mamie's overall condition made her ineligible.
It's a very serious disease. And you know yourself, without your lungs, you can't live. It's no future. You know, death is soon.
The Fen-Phen Mamie and others took wasn't actually a single drug. It was a combination of fenfluramine, sold under the name Pondamin in the U.S., and phentermine. Thus the name Fen-Phen. Both were diet drugs, but only Pondamin caused pulmonary hypertension, which was thought to be an extremely rare side effect. In the early 90s, the maker of Pondamin, Wyeth, and a partner company asked the FDA to approve an updated version called Redux, already on the market in Europe. Because it was so similar to Pondamin, Lutwak, in his review of Redux, investigated how much of a pulmonary hypertension risk it would pose.
When I started looking at the actual reports, it didn't seem that rare. And I was told by the company that, no, this just doesn't occur in enough individuals to make it worth being concerned about.
The question was soon clarified by Chicago cardiologist Stuart Rich and colleagues who were finishing a 3-year European study on pulmonary hypertension and diet drugs. Their results showed the risk for redux was real and increased the longer you took it.
What was particularly shocking to me was that on the heels of reporting that this drug caused a fatal, incurable disease in Europe, that the company was planning to put it on the American marketplace. When I had heard this, I said, well, you can try. It's never going to get in this country. The FDA would never permit a drug that had little benefit, terrible risk on the American marketplace. The FDA is your watchdog that looks out for your safety.
FDA reviewer Lutwak also believed the agency would not approve the drug.
According to what I read and the way I interpreted the Food and Drug Administration's role, we're supposed to evaluate drugs for their safety and efficacy. And when the safety is questionable, it requires an awful lot of efficacy for it to be warranted.
If you looked at the efficacy studies, you found out that its efficacy was minimal at best. 3% weight loss after 1 year. If you weighed 300 pounds, I could say, end of a year, I'll get you down to 291 with the risk of dying of pulmonary hypertension.
With controversy surrounding redux, the FDA called an advisory committee meeting to get the views of outside experts. Lutwak presented data showing that the average weight loss was unimpressive.
Use of the drug provided approximately 3 kilogram greater weight loss than the placebo alone. Physicians rarely think of it.
Rich was there too, warning about the dangers of long-term use.
Good morning, Mr. Chairman, members of the committee.
The drug companies that were seeking to sell redux also got a turn to speak.
40% of patients.
They presented data showing that some patients lost a lot of weight and argued that for society as a whole, obesity was more harmful than any side effects. Eventually, the 11 committee members had to come up with a recommendation, which the FDA could either accept or ignore. Let's go then to the second question: is the evidence of safety sufficient to warrant approval for long-term use? Dr. Collins.
My answer is no, and I guess.
The committee voted unsafe, so they voted thumbs down for safety.
I hope that we do a phase 4 study.
But they were leaning towards yes for efficacy. But if you're not safe, you're not going to get approved. That meeting was suddenly and unusually halted by Jim Bilstead, who was the director of the division.
In evaluating the benefit.
He was the FDA official overseeing the meeting. And late in the day, after several of the committee members had already left, he posed an extra question. Were the benefits of redux sufficient to make the risks acceptable?
I won't speak for the other members of the committee. Okay.
It was a rather unusual move, but some of the higher level managers, administrators at the FDA announced that a second advisory committee meeting would be held to review this in a few months.
It was at the other meeting where none of the consultants were invited to come back and testify that was approved 6-5 in favor.
Before that second meeting, Lutwak had agreed to support the approval of redux so long as there were restrictions that severely limited the number of people who might get the drug. But some of those restrictions were never adopted.
I was very disturbed. And then we talked about it internally within the division at the FDA. And there is one tool that's left, and that's the labeling. And so we would see if we could get the company to put these warnings in what's called a black box.
About 10% of all drugs have black box warnings. And these always appear at the beginning of the information sheets that come with drugs. Such warnings are never good for sales, and Wyeth documents show the company wanted to do everything possible to avoid a black box on the redux label. A top Wyeth executive explained the company's view in a deposition.
We have many responsibilities as a company. We have responsibilities to patients. We have responsibilities to those in the company, to those who support the research of the company, to shareholders, that we accept and produce appropriate black boxes, appropriate labeling. And there are many reasons, and to sacrifice a company's sales just for the purpose of accepting an approval with a black box is not a responsible action.
When the FDA sided with Wyeth, people at the company were jubilant. Leo Lutwak was devastated.
I thought it was wrong that the company was allowed to have a second chance at the advisory committee. I thought there were wrong decisions made. I expressed that. I started feeling enough heat to make me recognize that my opinions were not only not respected, but they would be disregarded and pushed out of the picture.
So Redux entered the market, joining the related drug, Pondamin. Now it was up to the FDA's MedWatch system to monitor any serious side effects of both drugs. The agency would soon be put to a severe test. The story begins in Fargo, North Dakota, at a small regional medical center.
Hi, Marley. My name is Karen. I'm going to do your ultrasound here this afternoon.
Ever since 1994, when millions of Americans began taking Pondamin as part of the fen-phen craze, young women were showing up here with strange heart problems.
Most of the patients that we saw came to us because they had a new murmur. There was an extra sound in their heart that the physician hadn't heard before.
Each time a new patient came in, echocardiograms were ordered to get a better look at their hearts. Over the course of 2 years, Karen Berger and fellow technicians saw 10 young patients with heart valve problems. With every heartbeat, blood was rushing around their valves in the wrong direction.
I just was struck by the unusualness. It was just very curious. We commonly see that in the elderly. The valve will get stiff and not open or close properly. But these patients were very young, and it just didn't fit.
Karen's curiosity led her to ask the very first patient if she was taking any medications. Marley Seward answered fen-phen.
I was taking fen-phen because I was morbidly obese. I was well over 100 pounds overweight, and this looked like the solution according to my doctor. There was some media, probably about 6 months after I started with it, on how fabulous this product was, and it was touted as a miracle drug.
What about a pill that tells your brain you're not hungry?
And I had to agree, because I was having the results that they said you were going to have.
And I had lost 31 pounds.
Take it off. Lose the weight with fen-phen or Redux.
I was on fen-phen for 15 months. And the first 12 months, it was the miracle drug. I was losing weight. I felt great. I was doing everything exactly the way they said it should happen. And then my miracle turned into my nightmare.
After hearing other similar stories, Karen and fellow technicians told the hospital cardiologists they believed fen-phen was causing valve problems. Cardiologist Jack Crary was skeptical.
We shared their concern, but we just couldn't substantiate it. When we look at the echoes, clearly there were valvular abnormalities. Their patients were on fen-phen along with other medications. And to go from one to the other, at least no one in the department was convinced that the connection was real.
Crary remained unconvinced for many months, until a patient of his own became a victim. One day she was fine, then soon after taking fen-phen, she had severe valve damage. In his head, he calculated that if so many people were getting harmed in a small city like Fargo, then huge numbers must be getting hurt nationwide. Crary knew the FDA was completely unaware of the possible heart valve problems, and he also knew he might have to pay a high price if he reported them.
There was going to be potential major litigation if this was real. I mean, I was very happy with my life. I didn't really want to rock the boat, but I couldn't just walk away from that and say, well, let somebody else sort this out. I just don't think that I would have been able to face another patient.
In January 1997, Crary decided to take action. Seeking the credibility of a prestigious academic medical center, he contacted the Mayo Clinic in nearby Minnesota and told them about Fargo's 11 cases. As it turned out, Mayo had 2 similar cases of its own, and one patient needed valve replacement surgery. After some back-and-forth discussions, in late February, a doctor from Mayo called the Pondamin and Redux manufacturer, Wyeth, to inform the company about the heart valve cases. Within a few weeks, Wyeth officials went out to Fargo and Mayo to investigate further. and concluded there might be a connection between their drug and the heart valve problem. It had been over 2 years since the problem was first noticed in Fargo, and now in mid-April 1997, MedWatch reports were finally on their way to the FDA. But there wasn't any red flag to alert the agency that a serious new side effect had been discovered. Wyeth simply met its legal obligation to inform the FDA through the MedWatch system. By mid-May, Crary was puzzled why the FDA hadn't taken any action yet.
I was frustrated enough that I called the FDA, and the person I talked to the FDA knew nothing about it.
Despite Crary's urgent call, the FDA treated his reports in a routine manner, until a call came in from Mayo 6 weeks later, saying they and Crary were holding a press conference.
Today, my colleagues and I from the Mayo Clinic, in conjunction with Dr. Crary from Merit Care in Fargo, North Dakota,
It was early July 1997, and this is how the world found out about the heart valve problems caused by the drugs known as fen-phen. Only now did the FDA swing into high gear, and within a few weeks, Pondamin and Redux were off the market.
In the United States, 2 highly popular diet drugs are being pulled from the market.
One is fenfluramine, sold.
Just before the withdrawal, the FDA discovered that from 1992 to 1996, Wyeth had actually sent in almost 24 MedWatch reports from Europe, which were headlined Pulmonary Hypertension or renal failure, but that contained clear references to heart valve problems.
The company had this information. The company had the information that people had heart valve disease. And that was reported to the FDA in a way that was very difficult to pick it out.
Without Wyeth red flagging the heart valve problems, the FDA didn't catch their significance. But it would be the company's failure to warn the public about these problems that would give lawyers their smoking gun.
Who knows where the FDA box is? It's a whole box of FDA documents.
I've got that one.
Okay.
Over 200,000 Americans have sued or are planning to sue Wyeth for damages. These are all videotapes of echocardiograms just at Kip Petrov's firm. To date, the cases have cost Wyeth nearly $13 billion, and in the end, it could cost the company much more.
This is probably unprecedented in terms of anything that's been seen other than perhaps asbestos.
It's too late for monetary settlements in the case of Mamie Johnson.
Happy birthday to you. Happy birthday.
3 months after we filmed her at her 65th birthday, she died from lung problems. As for Marley Seward, someday soon she'll probably need surgery, with all its risks, to replace her leaky heart valve.
I am mad, angry, frustrated for the fact that they took a good part of my life away. They may have taken a good section of my life away just by using this drug, and I do understand they're in the business to make money, but I'm in the business to live.
Wyeth declined Frontline's invitation to be interviewed for this program, but in a written response to some of our questions, they said the company issued appropriate warnings about Pondamin and Redux in letters sent to doctors and in the general cautions part of their labels. We asked the FDA's Deputy Director Galson what the agency learned from fen-phen.
Our system isn't perfect. It sometimes can detect things after other parts of the medical care system is able to detect it. In this case, what happened is some very astute physicians were lucky enough out in Minnesota to see a series of similar cases where they saw heart valvular abnormalities, and they put the link together. Again, looking at our data after the initial case reports that came in from the Mayo Clinic, we could see the signal. I think the lesson is that there's a lot of room for us to go in terms of making improvements with the system.
Some critics say the agency needs to learn more from disasters like fen-phen.
We need for the pharmaceutical industry something analogous to the National Transportation Safety Board, so that when a plane goes down, they go in and analyze what happened And they may find that the plane was the problem and the manufacturer, or they may find that the regulations were inadequate. But they're independent. When a drug comes off the market, we have no analysis to say, should it have ever gone on the market? Was it a mistake at the agency, or was it a mistake at the industry? Or was it something that was totally unpreventable?
But is the FDA ready for such scrutiny? In the aftermath of Fen-Phen, Leo Lutwak says he was actually punished for having opposed the drugs.
I didn't expect the Congressional Medal of Honor for this. I didn't even expect a $50 bonus for it. But it would have been nice if somebody had said, hey, you did a good job. And the opposite happened. I found myself trivialized within the FDA, and I was reassigned to areas that I found very dull, unrewarding.
Lutwak retired from the FDA a few months after Frontline interviewed him, and he is now consulting for plaintiffs' lawyers.
Before he could issue a citation against the manufacturer.
Back in the 1930s, when the FDA was originally set up, scientists there were encouraged to be skeptical about the claims made by companies. But critics say a major pro-industry shift occurred at the FDA. Particularly after this 1988 rally in front of headquarters. Demonstrators complained it was taking too long to approve new AIDS drugs. In response, Congress passed the Prescription Drug Users Fee Act, or PDUFA, a law that requires companies to pay up to a $500,000 fee with each new drug application to help the FDA hire more reviewers and get drugs onto the market quicker. Today, over half the FDA's drug reviewers are paid with industry money, and the approval time for many drugs has gone from over 2 years to less than 6 months. That's all good news, according to drug industry spokesman John Kelly.
The pharmaceutical industry has been pleased with PDUFA and has been very supportive because what it has done is to improve the efficiency of the review process. It's in the pharmaceutical industry's interest and in the public's interest to have that review process as thorough and effective as it can be.
The culture at the FDA has become please the industry, avoid conflict, look upon our role as getting out as many drugs as possible.
Sidney Wolf of Public Citizens Health Research Group in Washington believes industry funding has created an FDA that's reluctant to challenge company claims about safety and effectiveness.
This system has created a very unhealthy relationship between the industry and the FDA, where the FDA says, we have to be nice to these people because they are paying our bills.
Michael Elishoff thinks this new relationship partly explains what happened to him at the FDA 3 years ago when he opposed the approval of a new anti-flu drug called Relenza.
Who is it?
It's me, influenza. You know, the flu. Coming in.
Simply stated, Relenza just didn't work in the United States clinical trials. It really had no effect at all on the symptoms of influenza. It had no effect on influenza complications.
Introducing Relenza, a new prescription medicine to help you start feeling better sooner.
It maybe knocked half a day or less off the duration, and even that wasn't established statistically. So it was pretty much no different from placebo as far as efficacy.
Those with chronic lung disease or asthma may experience wheezing.
What also bothered Elishoff was a life-threatening side effect that caused some users to have trouble breathing.
Relenza is an antiviral medicine that's inhaled. You should be shown how to use the inhaler.
One of the concerns during the review was that Relenza had the potential to cause bronchospasm or constriction of the airway, and it was observed in several patients in the clinical trials.
To sort things out, the FDA called an advisory committee meeting. Elishoff told the panel of 17 experts that Relenza had little benefit and real risk.
Ultimately, they decided that it was not worth approving, voted 13-4 to reject the drug. The next day after the advisory committee, several people in FDA management told me that they blamed me for the drug getting turned down at the advisory committee, that I wouldn't be allowed to present at the advisory committee meetings in the future for any other drugs.
Elishoff still had to write up a formal review of Relenza, and here he says he got reined in again.
I was told very explicitly, don't write in your review that you're recommending against approval. Write that the data is unclear, you could go either way. So it was quite explicit.
Where Elishoff wrote that patients would be exposed to risks while deriving no benefit from the drug, supervisors weakened his report to say that safety data should be considered in making risk-benefit decisions. In the end, the FDA approved Relenza after the manufacturer, Glaxo, sent the agency a strong letter complaining that Elishoff was judging their drug by stricter standards than what had been agreed upon before the review began. 9 months later, the FDA forced Glaxo to put a new warning on the Relenza label, saying that deaths and injuries can occur from bronchospasm, the very thing that worried Elishoff. By then, Elishoff had left the agency after working there 5 years. He says his experience wasn't an isolated example of an FDA scientist being asked to brush aside bad news about a drug.
In nearly all the cases I was familiar with, both that I worked on and other people in my division worked on, there would be a pressure to approve those drugs or soften the language in the reviews, soften the language in the labels, so that they could have a more easy justification for why they're approving it. So I'd say it was very common.
Frontline asked the FDA's Stephen Galson about Elishoff's charge.
We're certainly not proud to hear that there's anybody that has opinions like that, but we just don't think it's average or even reflective of what most people think. We wouldn't condone anyone being asked to change their review. I think the idea of forcing someone to change something that they've written or something that they've analyzed is highly unusual.
It's a joke. I mean, it happens all the time. I guess the only reason it doesn't happen as frequently as it might otherwise is people start censoring themselves. That they say, okay, after the first time I've noted a problem and it's been glossed over, well, why bother the second time?
An investigation by Sidney Wolf's Health Research Group revealed that charges like Elishoff's are common at the FDA.
In the context of the large number of drugs that had to come off the market in the late 90s, we did a study of physicians at the FDA who are in the drug approval division and found that between them, they had identified 27 drugs that they thought were too dangerous to come on the market, but those drugs were approved over their objection.
In late 2000, soon after the Health Research Group study was published, the FDA completed its own survey about morale at the agency. Frontline obtained the results of this internal study. Among those who responded, a number said their reports were edited, and they had been asked to change negative opinions about pharmaceuticals. 1/3 said they feared being stigmatized if they recommended that a drug not be approved. And 1/3 also said that they were uncomfortable expressing differing scientific opinions.
I don't think it's characteristic of how our scientists feel. For one, this is a 3-year-old survey. For two, it was not done as scientifically as some of the more recent surveys that we've seen in the last few years. The people that work here are challenged, they're gratified, and by and large, they enjoy what they're doing.
Whether or not there are morale problems at the FDA, administrators insist safety is not being compromised.
For the consumer, they need to understand that the FDA's mission is to ensure that drugs are safe and effective before they are approved for marketing, and that the vast majority of medications meet that very high standard prior to their approval. We have, in this country, achieved extraordinary benefits from the use of pharmacologic agents. We as a society are living longer, and that in large measure is due to the high quality of the medications that we as a nation receive.
To demonstrate how seriously safety questions are taken at the FDA, administrators invited us to film a staff meeting about a drug that recently went on the market.
Now that the drug is available and it's being used by larger numbers of people, in fact, there are rare but severe cases of liver toxicity.
The meeting was held just for our cameras, and the name of the drug was kept secret.
Small
But the staff members took positions they had argued at a real meeting a little earlier.
None of the drugs that are available to treat this disease really provide a perfect remedy.
But this drug has a safety problem, and to the best of our knowledge, we don't think that that problem exists with similar drugs of this class.
The question was, what action should the FDA take in light of the drug's association with liver damage?
The safety problem is real, and at the very least, we should inform clinicians that this is what we see and this is what they expect, because this is a lifetime therapy we're talking about.
Right. Well, there are different kinds of remedies that we can imagine to apply, such as try to reduce the usage, but not necessarily removing the drug from the market.
The leader of the meeting, who used to work in the approval part of the FDA, proposed letting the company keep its drug on the market, provided it conducted more studies.
My concern will be, I think, the time of the action. I certainly wouldn't want to wait for 5 years and deal much more reports of this kind of severity.
Do you favor that we should give strong consideration to asking the company to consider withdrawing this drug?
This is what I would suggest, yes.
And your reasoning is that there are potentially other alternatives?
Yes.
I frankly don't agree with you, and the reason I don't agree with you is that I agree that there is a bad outcome in a very small percentage of users, but from the clinician's perspective, there is some merit to saying that clinicians should have some freedom of action in dealing with patients.
Over the next few months, the arguments that took place here became a contentious issue inside the FDA, as reports of liver damage continued to arrive. The safety staff wrote up a 37-page document detailing all the cases, including 9 deaths. And then, in March 2003, a public advisory committee meeting was called to review the safety of the product. Here, we learned the drug's identity. It was a medication to treat rheumatoid arthritis called Arava.
Discuss Arava.
The scientists who had argued at the internal meeting that the drug should be taken off the market were here, along with a senior epidemiologist and physician, David Graham, who's been with the FDA for 2 decades and who helped write that 37-page report. For months, Frontline had requested an interview with Graham, but FDA administrators would not let us talk to him on camera. The first thing committee members found out was that they weren't going to hear from the authors of the safety report, a message delivered by Dr. Sidney Wolf, who had petitioned the FDA to stop sales of Arava.
Despite this 37-page evaluation, which concluded the drug should be withdrawn from the market, none of the authors of this review were allowed to present their work to the advisory committee and to be questioned by you in terms of what you agree with, what you disagree with.
Making the FDA's presentation was a scientist not from the safety division, but from the division that originally approved the drug.
There was extensive confounding, and when I
He downplayed the significance of the MedWatch reports.
Other likely causes for liver toxicity in the majority of those cases.
Then he pointed to other databases where there were no cases, concluding his 1-hour presentation saying the liver problem must be very rare.
Cases did not occur in these large databases, so we can't really quantitate what the rate would be.
While Graham and the other safety staff members watched in silence, the pharmaceutical company, with its army of scientists surrounded by stock market analysts, got to make a 1-hour presentation too.
The first study we did was a retrospective cohort study using...
The company pointed to databases where they could compare the rate of liver problems associated with Arava, also known as leflunomide, to other rheumatoid arthritis drugs.
What we are claiming, based on the analyses presented here, is that leflunomide is just as safe.
That absence of real...
Towards the end of the meeting, a special consultant to the committee expressed concern that the FDA was ignoring its MedWatch reports.
Well, the database that I heard was so compelling, and all of this seems so wonderful that there is really nothing to show acute liver failure. These were sent to me. I mean, I didn't make them up. They were sent to me, and they were actually listed as either serious liver disease or liver failure. And going through them, I was unable to be absolutely certain that it was not.
As the discussion continued, suddenly, one of the committee members surprised everyone at the meeting.
The suggestion that the proceedings here are somehow tainted by the absence of individuals who wrote a report and the absence of our opportunity to have a colloquy with officers of the agency who may have differing viewpoints is a concern.
With just a little time left, it was almost 5 p.m. and the meeting was supposed to be over. The discussion was opened up to anybody who wanted to speak.
There is somebody who would like to comment, address Dr. Grabowski's comment. I think we'd be open to that.
Dr. Graham, who had been told by his bosses that he could not speak here, decided not to volunteer.
Yes.
In the end, the committee recommended keeping Areva on the market, despite the safety concerns raised by the MedWatch reports. After the meeting, we caught up with David Graham in the hallway. Now, he decided to speak to us without the FDA's permission.
We had a different perspective, and we really weren't given an opportunity to present our side of the story. And the people who did present, the reviewing division and the company, well, they didn't see a problem, and they presented. We found a problem, and we weren't permitted to present.
You were invited to go up and speak. I mean, why didn't you get up and speak when you were invited?
Dr. Goldkind had about an hour to present his analyses. The company had another hour to present theirs, and they were basically each presenting the same thing. I didn't think that much would be accomplished in a 30-second soundbite. This was a very hostile process, and let's leave it at that.
Critics suggest what went on at this meeting, and what's been happening inside the agency for many years, has a simple explanation.
He who pays the piper calls the tune. I think that a regulatory agency should be independent of the industry it's regulating.
Top administrators at the FDA insist that industry money isn't a problem.
We don't really feel pressure to please the industry. We feel quite independent among the scientists. We have a large number of mechanisms for assuring high quality of the reports that we do to make decisions about new drugs. So we just reject that we're actually influenced by that.
In fact, thanks to recent congressional legislation, the FDA's approval division will get more industry money than ever this year. And for the first time, the Office of Drug Safety will also get industry money to increase its staff for monitoring drugs after they go on the market.
The Congress has repeatedly looked at how it wants to fund the FDA. And so, once, twice, and again last year, the Congress decided that the best way to fund the FDA was to look to the pharmaceutical industry to provide a portion of the funds to help support review. That's the decision of the Congress.